situations of induction therapy. I will start with a short introduction and highlight briefly the different agents before going into details for the special situations. Since my early days in transplantation, I was aware about diagnosis and treatment of acute rejection in order to improve the short-term outcome. Yes, later on I became aware of the drug side effects, keeping an eye on the long-term outcome. And nowadays, I became interested in the minimization strategies with special focus on the induction therapy. Induction therapy refers to the initiation of intensive immune suppression in the initial days after transplantation. And as Dr. Hussein earlier on said, that there is a growing use of the induction agent as threefold increase in induction agent was noticed in the last decade, and more than 50% utilizing interleukin receptor antagonists in Australia, and more than 75% are using induction in USA. The rationale behind induction therapy is to delay the introduction of calcium and to augment the immunosuppressive strategies and to facilitate the minimization avoidance regimens, either to avoid steroids or CNRs. And the main target now is the special situations. Regarding the types of the induction agents, they are also depleting, including OKT3, ATG, Ostima, and NCD52, and on the other hand, non-depleting, including NCD25, melatacept, and others. Regarding ATG, in low immunological risk kidney transplant recipients with steroid withdrawal, it depletes T-cell effects in preventing acute rejection and potentially lowers the infectious complications. And low-dose ATG, 1 milligram the first day, 0.5 milligram next 3 days, may be superior to high-dose 1 milligram for 6 days. According to the cellular study, way for steroid avoidance and the correlation with no death, preliminary data highlighted decreased incidence of no death with steroid regimen. Regarding SIMO, it is the most common used induction agent the last 10 years, as a non-sensitization rise in SIMO increased from 10% to 46%, with BRA less than 50% it increased from 12 to 57, was higher BRA levels it increased from 90 to 63. Regarding the interleukin receptor antagonist, the infinity study was really intensifying myophobic dosing and semi-high risk and doing renal transplantation, achieving similar 3 years efficacy regardless of whether steroid was done or not. Comparison between data mesenchymal and SIMO in short term, SIMO may improve outcome in patients with high risk of acute rejection and their graft function, while on the other hand, the long term, there's similar outcome between both. Comparing mesenchymal and ATG, ATG was associated with expansion of clear blood cells, was sustained the high C4D most of the FOXP3 host of T cells. For mesenchymal and ATG, low dose rapid ATG may be better option compared to mesenchymal in terms of graft function, graft survival, and cost. Regarding the campus, it allows lower doses of the maintenance immunosuppression, thereby diminishes long-term adverse effects. It leads to good graft and patient outcome with no major difference compared to mesenchymal, tacrolimus, MMF, and 1 year. Tacrolimus for 2 months then shifted to rapamycin, lowers acute rejection, according to our group study 3 years ago. This study concluded 2010 to 2013, including 426 patients receiving campus, another number receiving Vasiliximab, and the conclusion was that CAMBREST-1H followed by CNI and MPH exposure with steroid avoidance reduced the risk of biopsy-proven acute rejection. Regarding rituximab indications, comparison between rituximab versus no rituximab for 2 years is lower acute rejection, no difference in CMV and decay infection, and depletes both class 1 and class 2 antibody by 70 and 86%. Regarding the data set with flavivincent, the benefit in the benefit extension study, comparing cyclosporin with data set, there was association with improved health-related quality of life, suggesting that the use of non-nephrotoxic immunosuppression may affect patient side effects and experience. The other monoclonal antibody, some humanized anti-interleukin 6, or novel target for B cells, anti-CD22, 40, and 20, and JAK3 inhibitors, and elitacept and rituximab. Elitacept has comparable results, but there's higher CMV, lower decay, and higher malignancy. Rituximab once weekly, subcutaneously, inhibits white blood cell migration. The recent one is the TOR-100 76 patients were treated for 6 months in phase 2 trial. Non-oncogenic targets for patient 5 to 10 days dose with acute rejection rate maybe 14%. The main point is a special situation was pediatrics, and I think Dr. Fatina will cover this in election. Is well tolerated interlocutor pediatrics. Vasiliximab induces non-cardiogenic pulmonary edema in 2 cases. CAMBAS was also safe, and CAMBAS seemed to show promising role to achieve adequate graft function with steroid-free regimen among low-risk pediatric patients. ATG was associated with good graft patient survival rate for 15 years with low levels of complications. Regarding the debate of induction therapy in living donors, Vasiliximab for steroid avoidance in living donor transplant yields favorable results, and it decreased acute rejection from 18% in 1998 to only 8% in 2008. Cymobolus therapy for living-related and living-unrelated is a comparable survival rate at 1 and 5 years. Acute rejection was 17% for living-related, 35% for living-unrelated, with no increased risk of infections and malignancy. Regarding the African Americans, CAMBAS and MMF, with tacrolimus having a target of 5 to 6 nanogram without steroids, have been reasonably safe after 3 years of follow-up, while CYMO and interleukin receptor and no induction, the acute rejection rate was 18 for CYMO, 26 for interleukins, and 47 for no induction, with improved 3 years of graft survival. And African American can undergo a second or a retransplant with outcome comparable to that in the primary one with ATG induction. Regarding the desensitization, there is a separate lecture for desensitization will be presented by dear friend Marwan Masri. Marwan will discuss the different diagnostic modalities and therapeutic options utilized for these patients, highlighting ATG, IVIG, rituximab, CAMBAS, plasma exchange, immunoabsorption, and I'm sure Marwan will present this better than me. Please, Marwan, allow me to cancel this in my talk and take it. Okay, عشان كده هنسيب. Regarding the ABO incompatible transplantation from ABO incompatible spousal donors was equivalent to transplantation from an ABO compatible spousal donors. This is a study for 174 transplants received plasmapheresis, vasiliximab, with splenectomy, and then tacrolimus or cyclosporin plus MMF. Graft survival for 1 year was 100%, and the acute rejection rate was 33%. Another option is to have one infusion of immunoglobulin and rituximab, one antigen-specific immunoabsorption, and transplantation can be performed without splenectomy according to different processes. Combining MO-compatible matched control to MO-incompatible for more than 700 living donor transplant. Long-term patient graft survival was not affected. Graft loss was significantly higher in the first 14 days, but there's little to no difference during the 14 years for the graft survival. Using rituximab and the plasmapheresis and ATG allowed everyone compatible living donor renal transplant with excellent result and reduced the cost. This study includes 1,400 transplants in 100 centers. Everyone compatible living donor transplant showed similar outcome to every compatible transplant over the same period of follow-up. Regarding the old donor age, low doses of cyanide were matched or much more effective to prevent acute rejection than those in old donor. No difference in both patient and graft survival rates at 3 years. Also, cyanide was effective at preventing delayed graft function among the patients receiving their grafts from older donors. Regarding older recipients age, this study includes more than 1,400 transplant about 65 years. 1,000 of them received Canvas 1H, and Canvas induction in elderly is associated with escalating risk of death and graft loss. Regarding all donors for all recipients, or for all, Bazriximab and short course fluid dose thiamine provided effective and safe induction in all for all situations with good renal function and without increased risk of infection. Regarding the hepatitis C, transplantation in HCV positive recipient improves survival compared to waiting list of these patients on the dialysis. Dilemma and the balance. Utilizing induction therapy, either depleting or not depleting for this patient, and what about the progression of hepatitis C that can affect the outcome. Data from organ procurement and transplantation network, hepatitis C positive patients received hepatitis C positive donor. There were around 7,500 recipients. Depleting is used in 1,800 and non-depleting in 1,600, and the results were comparable graft survival and comparable patient survival, and HCV donor cell positivity did not adversely impact either graft survival or patient survival. So, the supporting of the practice for transplant hepatitis C positive donors into hepatitis C positive recipient to alleviate the waiting list burden, and some advice to have the genotype. Recipient of HCV positivity should not influence sedation of infant therapy, as there is no difference between depleting and non-depleting. Regarding the delayed graft function, 153 diseased donor renal transplant all received Bazriximab at day 0, and then ATG positive group had 84 patients with delayed graft function, and the other group, ATG negative group, had 70 recipients with no delayed graft function. Duration of therapy was around 8 days. Start same therapy after 10 days. Cumulative ATG dose was 5 milligrams per kilo. This comparable frequency of infection and malignancy and 1-year patient and graft survival rates were 97% and 92%. Regarding the new era of HIV, this report having 4 patients, the interaction between CMIs and anti-retroviral therapy used for treatment of these patients. No acute rejection was favorable outcome of hepatitis of HIV-1. Regarding HIV-2 patient died due to severe infection. Another record for 13 patients using bath and steroids for 5 days. Then CMI and MBA. 4-year patient survival was 100%, and the 4-year graft survival was 89%. So, reaching to my last part of the talk, I would like to address the KDIGO, especially as a cooperation with the KDIGO right now with the society. And I am a member of the KDIGO group for living donor transplantation, and we completed already the file and will be published in November this year in the transplantation. The KDIGO advised administration of immunosuppression to renal allograft patients, AB grade 1A, and the induction with standard immunosuppression rather than standard immunosuppression alone is grade 1A. As a trend for more potent induction immunosuppression in Australia with Jeremy Chapman and his group, with TAC and MMF and basilic induction, or with ANI avoidance during the maintenance phase. Moreover, meta-analysis indicates that induction with biological antibody plus conventional immunosuppression is superior to the conventional immunosuppression alone in reducing acute rejection and graft failure. Interleukin-2 receptor antagonist is the first line of induction therapy, grade 1B. ATG rather than interleukin-2 receptor antagonist in high-risk patients, grade 2B. Interleukin receptor antagonist is recommended if ATG cannot be administered, grade 1B. And so, regarding the induction. Induction decreased the essence of acute rejection, yes. Induction decreased the severity of acute rejection, yes. Induction decreased the need for antibody treatment for acute rejection, yes. But what about impact of induction graft survival? Some authors reported yes, and other authors reported no. The same has a long-term outcome for basiliximab for 11 years and confirmed the phase 3 with no impact on graft survival, patient survival, and graft function. So this attempt to identify patients at high risk of acute rejection is an important approach for tailoring the induction therapy, and are awaiting the further advances in the immunosuppressive armamentarium. We should be able to improve the functional life of most renal allograft by tailoring our available agents, as Dr. Tarek said in his lecture, for induction and the maintenance therapy. And my ambition is to overcome the zero transplantation barrier and to induce immune tolerance, as our ancient Egyptians succeeded in transplanting of a human to a Buddha of the lion with no immunosuppression, with no rejection, for more than 5,000 years ago. At the end, I'd like to say to all the Arabic people, either Muslims or Happy New Year, and thank you.